my honor to welcome Steve Bullington, who is a senior partner at Jones, Skelton and Hachuli, and I probably totally slaughtered that. He has been practicing law since 1988. Is that right?
Yeah.
I thought it was 98 in my mind, but 88. He works in our medical malpractice field and has provided counsel for numerous physicians and institutions, and it is an honor and pleasure to work with him. He provides extensive knowledge to our team here at the RISK program. And then also Dr. Shukla, we are thrilled to welcome her. She is one of our pediatric hospital medicine colleagues. She also started our integrative medicine program, which is one of the most amazing programs we have, and we are lucky that she was able to do that. She's also very engaged in wellness, and so she'll be talking today about provider and staff wellness and the initiatives and programs we have here at Phoenix Children's. So with that being said, I'm going to turn it over to Steve, and welcome. Thank you guys for joining us.
Thank you very much, and I appreciate you letting me come here and address you. So about when I was in law school, I got to room with my brother Bob, who was an intern at the time, and he was at Good Samaritan, which is now Banner University. And I don't think I've ever seen anybody work that hard in my life. Not before that time and not since that time have I ever seen anybody who put in the hours and the dedication to be an intern and the amount of work he put in. Fast forward about 10 years, and I'm practicing here in Phoenix as a medical malpractice defense lawyer. And Bob has set up his practice as an ophthalmologist here in Phoenix. And he calls me and he's distraught. And he said, I got a letter from a lawyer putting me on notice that they're going to file a lawsuit against me. And he said, would you come over and meet with me? So I go over to his office and I meet with him, and he's got the patient's chart. And we go through it, and it's a pediatric case. It's about a 10-year-old boy who had a dart that went into his eye. And he had come into the ER, and Bob got called in, and Bob did surgery. He had seen the patient 5 times in his office, even though at the time it was an Access patient, and Access, I think, paid for 2 visits. But Bob saw the patient. In the last visit, he very clearly indicated that he referred the family to a retinal specialist. So I'm looking at this and I'm like, I can't believe that they're thinking about suing you. And so I call up the plaintiff's lawyer, I know him, and I said, hey, I know I'm biased and I know you're a very good lawyer, but do you have all the records in this case? Do you guys really want to pursue this case? I just want to make sure you have everything so you can make a good decision. And he said, well, make sure you send us everything and we'll take a look at it again. So I did. And about a week later, he calls me and he said, I agree with you. There's no case. We talked to the client. And so we've told them, don't file a lawsuit. And I don't think they will. So I call Bob and I tell him that. About 2 weeks later, I'm having dinner with Bob and his wife. And his wife says, thank you so much for what you did for Bob. And I said, you know what? I really didn't do anything. I just made sure they had the medical records. And she said, well, during those 2 weeks that this was pending, Bob couldn't sleep. He had trouble eating. He was so distraught over this. It upset him so much. But that experience with my brother, and over the last 30 plus years that I've been doing this, defending doctors and hospitals and healthcare providers when they get sued, it's given me a lot of insight into what you go through when you get sued, when a claim is made. And some of that, particularly for the new doctors here, the residents, the fellows, I think some of that is the great unknown of what is a lawsuit? What are my odds of getting sued? What are things that I might be able to do? And I'm not here to tell you how to practice medicine, but from a legal standpoint, what are the things that I've seen, mistakes I've seen people make, things that I think, things that have been excellent that doctors have done to decrease your chance of getting sued. Or if you do have a claim made, that decrease the chance that there's going to be a payment made. So I want to go through that. Some of this at the beginning is very basic about a lawsuit, but then I'm going to talk with you about the odds of getting sued, why people get sued, and again, tips about things you could do to hopefully decrease your chance of getting in a lawsuit. So in a lawsuit, the plaintiff has the burden of proof. And what do they have to prove? And what I'm showing you is what we show a jury in closing arguments. We explain to the jury that the plaintiff has the burden of proving that they have to prove that there was a standard of care, a breach, that there was a violation of the standard of care. And I put specialty in there because let's say you're a radiologist. They have to have a board certified radiologist on the other side to explain that you breached the standard of care. They have to prove that the injuries were caused by the alleged negligence. And then finally, they have to prove damages. And really, this is what we call the standard of care. And again, this is what the jury is. This is the legal definition of the standard of care. It's what a reasonable and prudent, let's say, pediatrician must exercise that degree of care, skill, and learning that would be expected under similar circumstances of a reasonably prudent pediatrician within the state. So what I tell juries is the standard is, was it reasonable? Not was it perfect? Not in retrospect, was everything just right? But was it reasonable? That's the standard of care. That's the legal definition in Arizona. Sorry about that. Ooh. So causation is the next step. And that is negligence causes an injury if it helps produce the injury and if the injury would not have happened without the negligence. Those are the two main things that a plaintiff has to prove. And they have to prove what their injuries are. But the causation, we call this kind of the but for. Would the injury have occurred without the alleged negligence? So let's talk about the odds. I'm sorry. I pulled this from the AMA, a recent article from the AMA about what are the odds of you getting sued. And I show you this not to upset your breakfast, but because it's amazing to me how many times I meet with a client and they feel like they've been singled out. Like, I can't believe I'm getting sued. I must be a bad doctor because I've got this lawsuit out there. And that just simply is not the case. So approximately 1/3, and this is, I'm going to show you on my next slide, something that seems contradictory to this, but approximately 1/3 in this report of all physicians, the AMA sent out a survey, about 1/3 sent back and said, yes, I've had a claim made against me or a lawsuit. And the riskier the specialty, the higher the risk of getting sued. That makes sense. And the vast majority of claims, and this is important, the vast majority of claims, about 70%, end up getting dismissed by the court. They end up, the plaintiffs drop the case, or for whatever reason, the case doesn't go forward and there's no payment. So only about 30% of those cases end up in a payment. And we do go to trial every once in a while. And of those cases, you know, of the ones filed, about 5% or maybe even less go to trial. And when we do go to trial, and I'm going to talk about this in my later slide, juries like doctors. And for good reason, they like and trust doctors. And the vast majority of the time, when we're able to explain to them the standard of care and use that standard of, was this reasonable? About 90% of those trials end up in a defense verdict. So what are the high risk and low risk specialties? This may influence your selection process, but and there's all different kind of surveys out there that talk about what is the risk of orthopedic surgeons. You can find all different kinds of numbers, but universally, here's what I have found, is that these are the high risk professions or specialties within medicine. And you can see a trend there. If you pick surgery, and again, this makes sense because it's higher risk. There's more things that are out of your control when you're doing surgery, more things that can go wrong. So, and by the way, trauma in these fields is much less than an elective type surgery. So for example, plastic surgery, if it's elective, patients are dissatisfied, and we'll talk about that, but it's much less if it's a reconstructive surgeon who's called in and does a trauma type surgery than it is if it's elective. The low risk professions, good news for you all. One is pediatrics, psychiatry, family medicine, derm, hematology, oncology. But even with that, and this was a 2011 study by the New England Journal of Medicine, even if you're in low risk, by the time, if you practice till age 65, there's about a 75% chance that you'll have a claim made or a lawsuit. So why do doctors get sued? The number one reason is a missed or delayed diagnosis, especially if it leads to improper treatment or a poor prognosis. There are obvious errors and complications, one of which, I mean, it never ceases to amaze me that I still get the case of operating on the wrong knee, and the doctor not realizing. I've had cases where a patient, with anesthesia caught on fire during the procedure. So you have those kind of obvious glaring mistakes, but also where a patient develops a really serious complication. And that is the catastrophic result. A lot of times we see those in cases where it's really no negligence at all on the part of the doctor. But if there's a catastrophic result with significant financial consequences to the family or the patient, a lot of times they look for where can I get some money on this? Patient expectations, and we'll talk about that. If they get a result that's unexpected, and I'm sure you've heard many times, you've got to create reasonable expectations for your patients. Poor communications with patients and other providers, and we'll talk about this, and I'm quite sure you've heard this a million times, but your bedside manner is critical. People don't like to sue people that they like. If they like you, if they respect you, it decreases the odds that they're going to sue you. The final thing that I see a lot is the need for an explanation. A lot of times I hear from plaintiffs' lawyers, this patient came to me because no one explained to them why their father died, why their child died, why they lost their limb. No one gave them a great explanation, so they came to me and they wanted to know. And trust me, you're in a much better, you would much rather explain a bad complication than have a plaintiff's lawyer explain why this happened. And so I'm going to talk about, some of these things, misdiagnosis, errors and complications. Again, I'm not going to tell you how to practice medicine, but some of these other things about patient expectations, communications, I want to talk with you about those things so that hopefully that decreases your odds of getting sued. And I would be remiss if I didn't say, this is another reason why people get sued. I told Carrie Hall that I was driving from San Diego back to Phoenix, And as I got to Buckeye, I thought, you know what? I'm going to start counting the number of billboards for plaintiffs' lawyers that I see. And I got bored after a while because there's so many of them. And now with the electronic ones, you might have 2 pop up by the time you pass it. But this is, there are times where I get, I get a case where it's just clear that the patient wants some money, and that's it. And I think this has a big influence on that. But there are other, there are definitely legitimate cases that we get, and there are, legitimate reasons that people seek out an attorney. So why do pediatric doctors in particular get sued? The most common I found, and this was from looking at, there's the American Academy of Pediatrics and the Doctors Company, which is an insurance company, did a review of claims that they've had over, I think, a period of 15 years. So meningitis is the number one cause, or the number one reason why people get sued. Missed appendicitis, pneumonia, congenital defects such as a heart disorder, and there are errors in medication and management, or medication management, failure to diagnose birth injuries. And again, these results are skewed because it's not the most common thing that as a pediatrician you might miss, because I think the number one thing as a pediatrician that you might miss is what I've read is that you might call a viral infection a bacterial infection and treat with antibiotics. That's the most common, but it doesn't lead to a horrible result for the patient. But when you have a missed meningitis, when there's a brain injury, those lead to lawsuits, because as crass as it may sound, lawyers, and as obvious as it may sound, lawyers are driven by money. And so when a patient goes to a lawyer and they think, well, this case is worth $50,000, they're not going to be that enthusiastic about filing. But if you have a brain damaged child, boy, they get really enthusiastic about filing. So my whole pitch is, how do you minimize the risk with the things that are in your control? And number one is good communication. And so when you talk with the patient, when you talk with the patient's family about a treatment, about a procedure, about what the diagnosis is, what the treatment is, you need to explain to them those things, set realistic expectations. If this surgery might help, but it may not help, set those expectations and document, fully describe the potential risks and complications. We'll talk about that. And document instructions for follow-up. What's going to be required of you in the future? Like my case with my brother that I was explaining, talk with the patient about, you need to see a retinal specialist, and here's the reason why. And so this is something that is particularly applicable to you guys, good documentation. And I'm going to talk about this in my next slide. But I know this has been harped on you, and you've got the EMR, which is probably the bane of your existence. But good documentation is the key, especially if a case comes to us and we go back and we're trying to figure out, okay, who did you talk with? Did you consult with somebody? When you got this radiology result, did you go down and you talk with the radiologist? We try to piece all of that together. If it's documented, then we can explain to a jury, look, it's in the chart, it happened. Otherwise, the jury may or may not believe that this is what was actually done. And I put in there, if the patient is non-compliant, make sure you put that in the chart. You don't have to say, make it sound like this is a terrible patient, but patient failed to follow the instruction. Patient did not follow up with the retinal specialist as requested. So don't be afraid to document that. And then another thing, some of the specialties have practice guidelines, and I'll talk about this. Make sure you're familiar with this. I'm sure all of you are familiar with this, but there are specific guidelines for, say, cardiology or the American Heart Institute about when you treat patients with certain medications. When is it indicated? Be familiar with those. And if you're going to deviate from those, have a good reason why. Because a plaintiff's lawyer is going to find those guidelines and they're going to show those to a jury. And they're going to say, gosh, doctor, why didn't you do what your own organization says you should do? And then I'm going to also talk about keeping a clean medical record, which is critical and which can make a very defensible case indefensible if the case is not clean or if the medical record. And this is, again, something I'm sure you all have heard, but address complications when they happen. When a patient has a bad result or if they're going through a difficult time, I think it's sometimes in our nature, I want to avoid that. Resist that and address it head on. Talk with the family. Let them know this is not a good result, but how are we going to get through this? And again, as I said earlier, this is why we find sometimes plaintiff or patients go to a doctor or to a plaintiff's lawyer because they feel like I was left out. No one came and talked with us about what treatment was indicated. No one told us once this complication happened, the doctor just disappeared. So let's talk a little bit about informed consent. And I think this is key because this is setting the patient's expectations. Every procedure that you do, every treatment that you recommend is going to have certain risks and complications. You've got to be familiar with those. You have to talk with the patient and talk with them about the common ones, talk with them about the serious ones, even if it's a low risk. And this sets the patient's expectations. And quick example, I had a patient who had a knee injection of a corticosteroid. The patient developed an infection. He turned around and he had a horrible course after that, but he turned around and he sued the doctor. And the doctor had put in his note, discussed risks of the procedure with the patient, including infection. If it's a known complication, with that in the chart, knowing that the patient knew that was in the chart, knew that that was a risk, accepted that risk, it makes the case much easier for me to defend. Describe the treatment procedure and the likely outcome. Are there going to be any limitations that the patient might have? And then again, document that conversation. Informed consent forms that you get from, say, the hospital, they're fantastic. They're good. But the best thing that I find is if you put it if you have a procedure note, discussed with the patient the risks of the procedure, like the steroid injection, discussed with the patient the risks and potential outcome of the procedure, including the risk of infection. That's very powerful if that's in your note for that procedure. And if you list every once in a while we have a patient who says, gosh, I had no idea. If I could have developed an infection, I would have said, no, I don't want to have the injection. Well, on a lot of these cases we get, they also sign a consent form saying, well, you had to undergo anesthesia for whatever procedure, and you were told there was a risk of death. So are you really going to say if there was a risk of infection? But put the most serious complication in your note And that makes it, that kind of takes the steam out of them, their ability to say, well, gosh, had I known that I might develop this minor nerve injury that was transient, I wouldn't have undergone the procedure. It takes the steam out of that. Finally, and again, I can't stress this enough, for pediatrics, the statute of limitations starts to run when the child becomes an adult. So about 3% of cases are filed more than 10 years after the care is provided. So if you are taking care of a 2-year-old, it may be 15, 20 years before that is filed. And so good luck remembering what you did with that patient. So that's another reason why I say it's critically important for you all to document these things. I'm going to give you a couple of examples throughout here, because I think if you're like me, this is the best way to learn, is where I've seen people kind of go wrong. This was an 18-year-old scoliosis patient who had infected Harrington rods placed years earlier, and he came in, the diagnosis was made, he was referred to an orthopedic surgeon. The original surgery was out of state, it was a military family, and it was care through the military. And the surgeon that I was defending, he had one preoperative visit with the patient. And he said, he recommended to them that I recommend that we remove the rod, we give you IV antibiotics, and then we'll put in new rods. Nowhere in his note does he discuss options, alternatives, risks. And the reason why is that he said, typically I would have more visits with this patient and the family before the surgery, but the patient's father was dying. And so I made an exception here. And these are the cases that always end up in my lab, are the cases that happen over the holidays. Or I made an exception here because the patient's, father was dying. So I didn't follow my normal routine. Those are the cases that invariably come to us, and there's some reason why this one didn't follow the normal course. So the family was asked, the doctor in the one visit he had with him, he said, I want you to go get some more spine films. They never did it. He also tried to get and never received a copy of the original operative note from the military hospital where the original surgery was done, and he was never able to get that. On the day of surgery, mom signed a hospital-generated, what I call a generic consent form. It says, my doctor has explained to me, I'm here for blank, and they put in removal of Harrington rods. And my doctor has explained all the risks and complications. No listing of the risks and complications, just that my doctor has told me. During the surgical procedure, the spinal cord was injured, and the patient was left with dense paralysis below that. The family sued, saying, we didn't get adequate information, your surgical technique was poor, and your preparation was inadequate. And the surgeon testified that, you know what, I did tell the patient, I always tell the patient about the risks, but it's nowhere documented in his chart that he talked with the patient about that. He admitted that his discussion with the family, as well as his approach, may have been a little different if he had insisted on them getting those films, if he had insisted on getting pre-op, the first surgical note. This case ended up settling in large part because of, you can see kind of there's numerous red flags in this case. There are things that I was very uncomfortable taking this case in front of a jury. And in particular, the fact that there's absolutely no discussion with the family, setting expectations, talking with them about the risks and what their options are. So when is a complication malpractice? because you will have them, no doubt, in your career. You've had them, you will have them. And is it a recognized complication? For example, I've defended a number of cases where a hysterectomy is performed and the bowel is nicked during the procedure. It's on the consent form. It's a well-recognized complication. Doesn't happen much, maybe 1%, 2% of all cases, but it happens, and it's a recognized complication. But was the patient told about that risk? Was the patient told, and this is where it's important to document, because if the patient is told, hey, there's a potential that we could nick a bowel, a bladder, a ureter, and they then sue saying, well, this shouldn't have happened, it's a much easier case for us to defend. And communication and follow with the patient. Again, in these cases, if you follow up with the patient, if a complication is encountered and you go and you meet with the patient and you talk with the patient, I'm going to get a little bit to that. But if you describe for them, if they know you are there for them, they're much less likely to file a lawsuit. Ultimately, experts will weigh in. In my bowel, nicking the bowel case, they have an expert who says, well, I think the surgical technique was poor. We have an expert on our side who says, no, she did everything appropriately. It's unavoidable. Ultimately, in our system, it's a jury decision of lay people to do that. But it's really helpful, again, if this is documented that the patient was told this can happen. Even if I do everything right, even if I try my absolute best and I'm at my best that day, this still can happen. So I talked earlier about guidelines and being familiar with guidelines. And this is a case study that I had. And some of these cases are adult patients, but I think you understand the concepts are the same. I pulled a couple of pediatric cases, but some of these are adult cases that I think illustrate the point really well. So this was a 35-year-old trauma patient taken to surgery. He had multiple injuries, and they placed a central line in the internal jugular vein. Post-operative X-ray confirms probably in the IJV. 2 days later, the patient's O2 sets drop, decreased mentation, and so the intensivist orders a CT scan. The radiologist who interprets it says no PE, but look at that. The central line is in the carotid artery. It's not in the jugular vein. He posts that note to the chart. He doesn't call anybody. He just puts that in the chart. And this was done at about 10 o'clock at night. The surgeon, 12 hours later, is going through the chart. He sees this X-ray report and he says, oh my gosh. And in the meantime, the patient has had a stroke. And so they sue, and they sue the intensivist, they sue the surgeon, they sue the radiologist. And this is the American College of Radiology guideline that was used to cross-examine the radiologist, where it says, if you have an unexpected finding, you have to directly communicate that to the ordering physician. And this radiologist, he came in thinking he could defend his care. And the fact that he posted it to the chart, and he said, well, they should have been looking for it because it's an ICU patient. In all ICU cases, they should be looking at this very closely. Well, why didn't you call somebody? How hard is it to call somebody? Isn't this your guideline that says you should do this? Why didn't you do it? And you can imagine he was on his heels the entire deposition. And again, a case that's settled. So it's important to be familiar with these protocols. So another thing that I see is, when is it okay to modify the medical record? Absolutely never. Absolutely never do it. Timely chart entries are crucial, not only for the patient care and safety, but for accuracy and credibility. Late entries, and I'll show you a case on that, can be devastating to your defense. And there are times where you're going to want to make corrections, or you may want to add something. But when you do that, clearly label it as a late entry, as an addendum, explain why you did it. If a lot of time has passed, if it's a month later and suddenly a claim has been made, don't go back and modify the chart or add an addendum, but date it, time it with the current date. And I had a case, I'm just going to put this all on here. And again, this was an adult patient, but this was the most glaring case I've had where a doctor does a prostate cancer surgery. He does a robot-assisted prostatectomy. During the surgery, he encounters all kinds of adhesions that he didn't know were there because the patient forgot to tell him that he had a hernia repair surgery with mesh when he was 20. So the doctor aborts the procedure. He goes out, he speaks with the wife, and the wife says, you know what? She is just irate. And she tells him, we're going to file a claim against you. He's going to have more, have to undergo another surgery. She blew up with him. So he goes back, and a very nice, honest doctor, but he looks at his original note and he says, I forgot to put in there that I had this discussion with him, that he forgot to tell me that he had this hernia repair surgery. And I always tell patients, there's always a chance we'll have to close if we encounter something and we might have to come back another day. And so he added those things to his chart. And what he failed, and he didn't date it, it wasn't an addendum, he just added it to his note that day. And unfortunately, what he had done is before the surgery, he'd sent his pre-op note to the hospital. And so there's two versions of his pre-op consult with the patient. This case went to trial for that reason alone. It was a terrible case. There was no malpractice, but the plaintiff's lawyer was so dead set on pointing out that my client had altered the record. He thought that was such a sexy issue that he could get the jury to really dislike the doctor. Fortunately, the jury found in his favor, but at the end of that, he was broken down and literally in tears about what happened in that case because, he got dragged through it for this sole reason. So another couple of points and then I have to sit down. The EMR records records everything. And again, I know this is the bane of your existence. These next few slides are all about paranoia, which will create some paranoia. But you need to understand that every time you enter a patient's chart, you are leaving fingerprints. Every time that you open the chart, areas that you go into the chart, if you make any changes, all of that is recorded. And presume that a plaintiff's lawyer is going to request what we call the audit trail for the chart. It shows every time anybody entered the chart and what they did. And so if you go in late, if you make a late entry, it will be recorded. And so my case study on that was a radiologist who, in the very short version of this, is a radiologist interpreted a CT scan of the abdomen in a patient who had had gastric bypass surgery. And he was deposed and he felt very confident in his defense. And he said in his deposition, that lasted 4 hours, through part of it, the plaintiff's lawyer said, how long does it take you to interpret a CT scan like this? And he said, well, to open it, to read it, to dictate my report, probably 10 or 15 minutes. And he said, oh, so that's your standard. That's how long it takes. He goes, yep. Got him very clearly on the record. And then the plaintiff's lawyer requested the audit trail for the chart. It showed that for that the doctor had been in looking at the film and dictating his report 1:51. Now, to those of you who may be radiologists, you say, I could do that. I can interpret in that time. But to lay people, the jury who's ultimately deciding the case, they may not believe that that was adequate time, and especially where there's a miss claimed. So the EMR records everything. And this is what I want you to be thinking about when you access the EMR. Now, the other EMR, a couple of things. With the cell phone, I never used to have this early in my career, but we have a case going on right now where mom comes in and she records, without the doctor's knowledge, records the entire visit with the doctor. Every visit she has with the doctor, she sets her phone on record, doesn't tell the doctor, and she's recording the whole thing. I literally, at the end of one, she's walking to the elevator. I can hear her footsteps. She just keeps it on the whole time. And that's legal in Arizona. We have a one-party consent rule, which means that if she consents to it, she doesn't have to ask you. She doesn't have to get your consent. She can record the conversation. The other thing is anything you record is evidence. So if you take a picture in a surgery or you take a screenshot of anything, the vocera messages, all of that is evidence. Couple of last quick things. The I'm sorry statute, any statement, affirmation, conduct expressing apology, responsibility, liability, sympathy, commiseration, this is from the statute, condolence, compassion, or general sense of benevolence is not admissible in a medical malpractice trial. So this gives you some protection when you go and you talk with the family and you say, I'm sorry, this isn't the result we wanted. So there's an Arizona Supreme Court case that upheld that decision or that statute. And it's where an OBGYN and the delivery of a twin, the second twin got stuck and ended up with a brain injury. And the doctor sat down with the family and he said, I'm really sorry about this, about the outcome. I feel like I let you and your husband down. And the judge said that doesn't come in, and the Arizona Supreme Court upheld that. So don't be afraid to talk with the family. Don't be afraid to talk with the patient. So I'm going to skip over this one because I'm out of time. But I will just say a couple of last points. There's confidentiality. If you do get a claim, if you do get a notice of something bad happening, if you go and you speak with your colleagues, if you speak with your partners, that's not protected. If you speak with risk management, if it's anything to do with, with peer review, your spouse, with meeting with a lawyer, that is absolutely privileged. But just assume, in the case that I was going to tell you about, is where a doctor said, I showed all of my colleagues an echocardiogram. He'd been sued. And the plaintiff's lawyer said, have you reviewed this case with anybody? And he said, yeah, I talked to all of my partners. I showed them the echo that you said I read inappropriately. And she said, all right, I want to depose all of them. And the court let her do that. My last slide is, I think a lot of times people believe that if I am sued, this is going to destroy me. From a professional standpoint, as I've shown you so many times, doctors do get sued. And if it's not going, unless you have repeated cases, unless it's an egregious case where you've done something almost intentional, it should not affect your credentialing. It should not affect you in front of the Arizona Medical Board. It should these cases happen all the time. you get through them and it doesn't affect you professionally. Personal considerations, and this kind of leads in to the next presentation, but financially, it should have absolutely zero impact on you. If you're an employed physician, you're covered, in this case, by PCH. If you have insurance, your insurance. I have never had a client have to pay money out of their own pocket for anything related to a lawsuit. The difficulty is the time. It does demand some of your time, and there is emotional that goes with it. And that leads into the next presentation, but I appreciate your time. Thank you very much.
Right. Well, thank you so much for that, Steve. That's really helpful information. So I want to talk a little bit about the resources that we have available. Because like he mentioned, this is a very traumatic experience for any provider who's going through it. Having been through it personally, I can attest to that. I don't know, probably many of you in this room could. And so I wanted to point out some resources that are available for you if you are experiencing something like this. There are a lot of things that are in your control that you can do to build up your own personal resilience to help you meet that moment. And we have a lot of great resources through our HR employee wellness program. And I've just listed some links and stuff here. I think the slides are available to everybody afterwards. So you should be able to just link directly, but this is also all on index. But also in the moment when you're trying to cope with the stress of this, if you're feeling overwhelmed, there are a lot of, again, more resources through our Cigna Employee Assistance Program as well. And we have 2 on-site employee EAP counselors here on main campus that are here during the weekdays. And then outside of those hours, or if it's a very urgent need, Cigna has phone numbers that you can call. You can go to their website and find resources. And then, of course, there's always the crisis hotline that you can reach out to. You can dial 988, or you can just text home to 741-741. Within our organization, we have a ton of resources as well. So we have the Medical Staff Professional Health Committee, which is available to support any provider who is experiencing any sort of impairment due to physical health, psychiatric health, emotional health, substance abuse, like any of these things that could be impairing your ability to function at your best day to day, and help you come up with a plan to improve where you're at and meet those goals. It is a safe space. It's non-punitive. It really is purely a resource. And you can either coordinate with your division chief if you're concerned about yourself or a colleague, or you can self-refer and you can just reach out to Dr. Fundabicini, who's the chair of the committee. Ooh, don't know what happened to that slide. Also for graduate medical education, we have robust wellness program and lots of great resources for our learners, not just for kind of in the moment stress, but even things like for managing fatigue and just overall wellness. And then Jennifer Faribault is a phenomenal resource. So, do not hesitate to, I'm seeing people nodding their heads. Do not hesitate to reach out to her. This is the suicide awareness hotline. So again, that 988 number, you can call 24/7 if you yourself or someone you know is in a moment of crisis. And again, I listed a bunch of resources here. There are links also if you're just interested in learning more about suicide awareness and prevention and what to do, and having tools and resources at hand to support your colleagues, or if you're a leader, maybe just to be aware, you can look at the resources that they have available there at those links. And then just real quick, I'm talking a lot about things that you can do for yourself. And it's absolutely very important. We know that we need to be at our best to function well in the hospital, and to take care of our patients and to make the best decisions. But, when you think about wellness as a healthcare worker, it is a much broader picture, not just personal resilience. And I know many of you probably heard me give this spiel, but I like to emphasize, physicians come into this job as some of the most resilient people in the US population compared to the general population. And it isn't until you put us into a healthcare setting that we start seeing the discrepancy between work-life integration, like the dissatisfaction with work-life integration and higher rates of burnout. And whereas for most people, having a higher degree of education is actually a protective factor against burnout, for physicians, it's not. And even within the healthcare industry, there is a difference between various fields. I also like to point out that burnout and depression are not the same thing. They have different impacts and they have different treatments. And so the approach is going to be different. And burnout is very much an occupational syndrome. So yes, building up your personal resilience, taking care of yourself is very important, but we need to look at that bigger picture and be advocating for, the support in the system to help prevent burnout. And also burnout actually can lead to increased rates of medical errors. So, we can look at a couple of different models here. The circle one is Stanford's model of professional fulfillment, which is kind of how they define wellness in the healthcare setting. And as you can see, personal resilience is definitely a big component of it, but the culture of the organization, the efficiency of the practice, those are also huge components of it. And the colorful hexagons up there, they're the AMA's model. And they just show various different factors that, if you tip the balance in the wrong direction, you experience more burnout. But if you tip them in the right direction, you actually have people who are more engaged in their careers, excited to come to work, participate in the things that they really enjoy, join committees or take on a research project or do more education, those kinds of things. And so we know that there are a lot of factors besides just the personal resilience piece. And I'm not trying to put all of the onus on us as individuals. I'm trying to, make sure we are advocating for the broader picture here. There is definitely a business case for well-being, and just for the sake of time, because I want to make sure you guys can ask some questions. There are many systemic factors that have been identified that impact wellness in the workplace setting. And the answer for this is all of the above. That's understanding staff needs and their engagement at all levels. Having leadership that is visible, accessible, approachable is very important. But also leaders that not only show support for well-being, but also have an understanding for it. So investing in their training and education is also an important factor. And then also, again, the answer for this one is going to be all of the above. There are many costs to burnout for the healthcare organization itself. So turnover can be a huge cost. To replace a physician can be 2 to 3 times their salary. Academic medical centers have additional costs that you don't necessarily think about, like the experience level that those more seasoned colleagues bring and then they take with them. You lose mentorship and decreased grant funding, and there's so many other factors that play in. Burnout leads to decreased productivity as a whole. And then, like I said, more medical errors. And so then you have increased costs that come along with that as well. And then patients recognize when we are not well, they know it. And we see it in our communication style, in the errors that are happening. And they're going to go back and they're going to talk to people and they're going to say, don't ever go there. It's terrible. Or you should definitely go to Phoenix Children's. It's phenomenal. They're the best. And their providers are also going to notice. And so we see a hit to the organization from decreased referrals from providers and also from patients not wanting to come. So our goal is really to move towards this well-being 2.0 model, where it's not just a matter of like, hey, here are a bunch of resources, go home, eat your vegetables, do some yoga. Really, it should be a collaborative effort, a joint, like a common understanding of what the needs are, and working together to move forward towards well-being for everybody involved. And most healthcare organizations follow this sort of roadmap as they sort of develop their well-being programs within the organization. And it usually starts at sort of grassroots levels. And then increasingly you have committees and more support and leadership buy-in. And ultimately you end up getting a full support and infrastructure and leadership focused on wellness in the organization. And I'm very happy to say, having been here for a long time, that Phoenix Children's definitely is progressing along this path forward. And I want to just encourage you guys to like keep getting involved and doing the things that you're doing. And so in 2 minutes, I'm going to just run through the many slides I have left of all the amazing things that are happening here. So we have the Professional Health Committee, which I mentioned earlier, and they felt like, besides just treating providers who are experiencing hardships. Let's proactively approach this. And so created this medical staff provider wellbeing committee, which I'm chair of. And our goal really has been to focus on not just providing sort of education to individuals, because our HR department has a phenomenal resource. Really, we've been focusing on how do we foster more organizational change. And one of the things we've decided to do was to create this network of division wellbeing directors who we actually currently have about 27 wellbeing directors. That's over 50% of our divisions are represented. And they have an onboarding process where they undergo orientation. We explain all the resources we have available. And then we have ongoing CME faculty development sessions for them for skill building, resources, communication, all those kinds of things, QI. And we also pair them with the committee members so that they have a mentor in the that they can reach out to for any work that they're doing in well-being. And really, our goal is for them to be able to work at their local level and meet the needs of that team, because we know there are different needs in different teams, and then also be able to collaborate with each other when we need something larger. And this is just a highlight of some of the accomplishments from our wellbeing directors. And as you can see, they're kind of a wide range of ways that they've been able to make an impact in their groups. And so again, just encouraging you guys to like stay involved and find these things that you can do. And it's not all about like having a social event or a happy hour, you know, anything that improves your practice efficiency can help with the well-being. Anything that improves your quality of care can help with the well-being. So just know that there are lots of things that we can do. Healthy work environments is another initiative that PCH has gotten involved in. It is part of a national collaborative from the American Academy of Critical Care Nursing. And over the past 20 years, they've really kind of refined these 6 criteria that they've defined that are necessary for healthy work environments. And they, again, use QI processes to like really implement changes and make a difference, and have noticed that they're able to improve metrics across the board, whether it be for patient outcomes, provider outcomes in terms of like turnover and hiring and things like that. And also for the organization as a whole in terms of the financial benefits that the organization experiences. And here are some of the projects. You guys can look at this later. We have 3 pilot areas, and then we have an overarching project, which based on our initial survey results, we wanted to focus on workplace violence prevention, and then realize there's a lot of amazing work happening in that already with the committee that exists. And so again, highlighting another committee that is doing amazing work and has made tremendous progress. You guys may have noticed these new signs that are out everywhere that are supporting our staff. And they have put together incredible education and training programs that are available to our staff. If you're interested, you can access their information on Index. Graduate Medical Education has a whole committee dedicated to wellness. And we've had a bunch of projects throughout. Some have been presented as posters, and then all these other amazing things. Schwartz rounds, we have lactation advocacy, we have the Women's Medical Alliance, we have surgical collaboration. Our hospitalist division has a peer mentorship program that is absolutely phenomenal. And then the last one, I'm going to leave up to you guys. Any questions for either of us?
Time for a question. I just have a question from a legal standpoint. Is a lot of the examples you gave are procedure related and complications that can be mitigated by good conversations about risks. We don't do a lot of procedures, so how do we protect ourselves from like the misdiagnosis? What's the best way to say in the chart, this was a differential we thought of, we thought it was this because of these factors? It's just a matter of explaining our clinical reasoning behind the decisions we made about a diagnosis and treatment.
And that's.
Can you repeat the question, Steve?
Sure. Okay. So great question. And you kind of answered it yourself. And that is that if you just put in your note, you're thinking about, maybe you believe that this patient has a viral infection, and that's the only thing you put in the note, then it doesn't give that much information. If you put a differential in there and you describe, have spoken with the family, we believe that this is meningitis, let's say, but it could also represent these other things. This is the testing we're going to order, and follow up from there. It gives some idea of what your thought process is. And again, if it's 2 years, if it's 10 years down the road, if the issue comes up, you can go back and go, oh, okay, this is what my thought process was. And it explains that. I don't know if that answers your question.
Steve, related to that, what if it's one of your colleagues that you think might have missed a diagnosis or something, and you have to talk to the parents about that? What do you recommend in terms of talking to them about that without kind of throwing your colleagues under the
Right.
bus, so to speak?
And that was a couple of my slides that I buzzed through, and I'm glad you asked that, because it was when I was sitting there going, I wish I had been able, because we talked about saying, I'm sorry. Be careful about saying, I'm sorry for this guy. Because those are the cases I get too, all the time. And it's one of my examples, and it was a pediatric case, so I wish I'd have been able to talk with you about it. But it's where patient goes from my orthopedic surgeon to a second one. And the second one said to the family, this never should have happened. And there are going to be cases, whether it's radiology, I think that's particularly tough, where you look back on this previous film and you go, wow, I can see that tumor there and they didn't catch it. So how do you talk with the family about that without throwing your colleague under the bus? Even if they're not here at PCH, they may be at Banner, but how do you talk with them? Maybe you say, you know what, in retrospect, I've gone back knowing what I see today and knowing where this tumor is. It looks like it was probably even there on the early one, much more subtle, but it looks like it may have even been on that prior film. That's a far cry from going in and going, wow, I can see it on this prior film. It's obvious. I don't know why they missed it, but we got it. And so it's been there for a year or whatever, but be very careful. And I just got a bunch of kids. So as I always, the do unto others, think about what you would want a physician following you to say to a patient about, why did he miss this? Why didn't they pick up on this diagnosis? You know what? This is super rare. We almost never see this. We almost never see meningitis anymore because of the vaccinations. And so, I understand why they didn't get it, but it looks like this is the diagnosis. So how you present that to somebody is critical.
Thank you.
I think we need to leave now. Just one more. There's a quick recommendation in the chat or from the Q of A. It said, great lecture. Just a comment regarding credentialing and lawsuits. It can affect credentialing if you do not disclose a lawsuit in your paperwork. Credentialing finds ways to find all lawsuits you've been involved in. So bottom line is, don't try to hide anything. Okay.
Same for the medical.
And there's a lot of resources internally, free risk, legal, quality, so please reach out. You have a lot of support from all of us. So thank you guys for attending.
Yeah, thank you.
No worries, that's fine. It's like